Okay, so let's move ahead with sub-I presentations, and I'll work with you to set that up at a time that makes sense. We're inviting back Gianina Hernández Márquez. She was with us for a scholarly year this past year, working with Dr. Germano. So I've introduced her recently before, and she's a student from the University of Puerto Rico who, did her bachelor's at University of Puerto Rico and then has completing medical school at San Juan Bautista School of Medicine in Puerto Rico as well. She did excellent work with us over the last year here and is going to present on, I believe, on some of her work with Dr. Germano. So Gianina, I'll give you the floor.
Morning, all. Just give me 1 second. Can you see my screen?
We can.
Now, is it in presentation mode?
Yes, it is.
Thank you. So, I apologize. So good morning. Today I'm going to be talking about the longitudinal assessment on post-treatment high-grade gliomas with artificial intelligence, specifically their role and the limitations that we've found. So in terms of disclosure, I, as Dr. Morgenstern mentioned, have done this work as part of my scholarly year here at the Department of Neurosurgery at Mount Sinai. And here are the disclosures of my mentor, Dr. Isabel Germano. To introduce the study, so high-grade gliomas are very aggressive tumors that require us to closely monitor them, specifically their radiographic treatment response to differentiate between progression and pseudoprogression. And this longitudinal follow-up of tumor response has been previously done using the response assessment in neuro-oncology criteria, otherwise known as RANO criteria. And further on, this RANO criteria has been modified, and it has been integrated using volumetric instead of bidimensional measurements, and this one is now known as modified RANO criteria. This modified RANO criteria specifically includes the state of disease, as well as the non-enhancing component, which was previously integrated in the RANO criteria. Now it's thought that it should not be taken as much in consideration. And so machine learning success, including deep learning and artificial intelligence, has fueled research on automated tumor segmentation tools. And the aim of our study was to validate the use of an FDA-approved AI software known as the NSH-Glio version 1 for monitor these treatment response in high-grade gliomas. Here, I wanted to present the RANO criteria versus the modified RANO criteria. So on the table on the right side, we see that the RANO criteria takes into consideration the enhancing disease, the T2 flare, the presence or not of new lesions, as well as if the patient is on steroids, and their clinical status. And then it's designated as having complete response, partial response, stable disease, or progressive disease, depending on the percentage change and all of the other factors that I just mentioned. And then the modified RANO criteria, as I mentioned, now takes into consideration the volumetric change. And as you see, the percentage change is different regarding the different states of disease. So in our study, we decided to use two publicly available data sets, the Akron data set, as well as the Lumiere data set, to extract subjects that had compatible MRI sequences with the requirements of the FDA-approved software. So the Akron study database contained baseline and longitudinal follow-up of 123 subjects with recurrent GBM. It was able to provide us bidimensional as well as volumetric comparisons that were measured by expert clinicians. And then the Lumiere study database provided longitudinal follow-up MRIs of 91 patients with GBM that were undergoing standard treatment. The Lumiere database provided volumes that were calculated by another AI software, Deep Rotum IA, but this was further verified by a neuroradiologist. So the entry criteria included the availability of the 4 sequences, T1, non-contrast, and T1 with contrast, T2, and T2 weighted, and flare sequence. Also, the parameters set by the brain tumor imaging protocol had to be met, and we also needed there for not to be motion artifacts. So for the 2D and 3D comparison, we compared the baseline MRI, or the lowest point of area in the MRI, to calculate percentage change between each time point. And then these percentage changes given by the data sets were compared to the percentage changes that were calculated by our AI software. And after that, we assigned RANO and modified RANO criteria for scores, and these were compared with the ones that were given by the 2 data sets. So here I included the demographic and clinical variables from the Akron database. As we can see, most of the population that we were able to extract was class identified as white. And here I also present the demographic and clinical variables of the Lumiere database. And the this data set also provided overall survival, as well as the molecular profile, which is something that right now is gaining a lot of it's gaining recognition, and it's showing to be very valuable in terms of treating the patients and giving a more targeted treatment. So for the results in the Akron data set for the 2-dimensional measurements, 19 patients met criteria. And in the 3-dimensional measurements, 19 subjects also met criteria, but these patients, some of them overlapped, some of them did not. And we were able to extract flare images from the 3-dimensional cohort, and 22 subjects met entry criteria for a total of 84 MRI data points. And then in the Lumiere data set, 415 MRI data points belonging to 24 subjects fulfilled entry criteria. And for this, we were able to extract from T1 with contrast, flare non-contrast, and necrosis. And then at the bottom, I just wanted to depict, I know I previously showed this, but to show it to the new audience, what the software shows us. So we see how the software is able to segment the different images, and it shows us the delineation of the enhancement in red, in yellow the necrosis, and in blue the edema. And we can see the different sequences, compare them side by side, and see a more visual representation of how the tumor is progressing, or if there's pseudoprogression. Here, it gives us axial, as well as coronal, as well as 3D and sagittal views. And then it also provides us a graph, which shows us the progression over time of the different volumes. And here we can see how at the top, it shows the imaging, in the middle, the volume changes seen over time. And in the bottom, it's able to calculate us this change in volume. And then we added a table that shows how the RANO criteria classifies the different states of disease. And so for the results, after the comparison of percentage changes between the Akron database and the AI software that we're using, we did not find a significant difference in terms of percentage change. And then in the Lumiere database, we also did not find significant differences in terms of the volumes of edema based on flare and on necrosis based on T1 with contrast, comparing both AI softwares. Yet we did find a significant difference in terms of tumor burden on the T1 with contrast images. And after an analysis, we found out that these differences in measurements came from the post-op tumor volume. 20 of them were observed. And after these were removed, we did not find significant differences. And so it's been known that the post-op MRI is more complex. It includes post-surgical changes, and specifically increased permeability in terms of the vascular structures. And it's possible that the software needs further refinements in order to better calculate the volumes. And so an investigator blind comparison is being done right now to better understand this and to refine the software more accurately. So the assessment of tumor response has been historically done by experts, as I've mentioned before. There's various criteria, including McDonald, RANO, modified RANO. There's also an immuno RANO criteria. Because this rating may be subjectable and there may be inter-rater variability, new technologies such as this one are showing to be powerful and a powerful instrument for accurate assessment of tumor response. And if we go back to the Akron database, the lack of significant differences between the experts or the neuroradiologists and the AI software seen in the 2D and 3D calculations validate the accuracy of the calculations done by the software. And Mayer et al., which is a study found in the literature, also saw this, that the automatic results and the manual results were very similar. So our study further strengthens the accuracy of automated segmentation tools for monitoring treatment response. And then in the Lumiere, the differences seen in terms of tumor burden that resulted in modified RANO criteria discrepancies warranted, as I mentioned as well, a more thorough examination. This post-op MRI was the source of the significant differences. And also I cited here other studies that have shown or have identified how this post-op MRI tends to overestimate tumor residual. So definitely the software needs a more targeted refinement that is currently in process. And we think that even though this is needed, the advances in technology and the advances in this software are showing to have great potential for longitudinal assessment of high-grade glioma treatment response. And so in terms of the limitations, the raw data that was published by these databases was not as granular as we expected. So we were unable to obtain clinical and steroid data, which is another factor that's taken into account to assign RANO or modified RANO criteria. And also the MRI scans, since these studies, specifically the Akron one, is not as recent, some of the MRI scans did not adhere to the accepted parameters. So the software was unable to analyze them. And to conclude, prior work was focused on the capability of segmentation tools for automated longitudinal brain tumor size measurements and the comparison of bidimensional tumor measurements, which has been highlighted to be potential for AI to further diagnose, to further increase the diagnosis accuracy. So our results corroborate the role of artificial intelligence in facilitating this differential diagnosis between tumor progression and pseudoprogression. And we want to apply this to prospective data to corroborate the results that have been seen here. Here are my references. I want to thank my mentor, Dr. Isabel Germano, as well as Dr. Puneet Bilani and Ali Abayasid for their contributions to the study. If there are any questions.
Thank you, Gianina. Does anyone have any questions?
I want Gianina, fantastic talk. Really fascinating area of study, and this year's a lot of work and well presented. The questions I have are sort of what you brought up at the end, and then one of the things that's always been interesting to me is the variability in flare sequence with treatment, tumor, and over progression. And have you been able to, or is it possible to differentiate, how the flare signal changes in addition to the overall volumetric and other contrast signaling? Is there a way to be more differentiated in the augmented, analysis?
So actually, the Rano criteria did take into account the flare sequence, but after further studies, when the modified criteria was presented, they saw that it presented more variability. And so they decided to not take it into account. I believe it does contribute, but apparently it seems to not be as accurate as these other sequences in terms of assigning progression or pseudoprogression.
Got it. Thank you.
So right, it's still work in progress, but I think with AI, the flare can be better calculated and therefore